Hi, my name is Jason Weger. I'm a professor of nursing at Oklahoma City Community College. And today we're going to talk about emergency medicine. And we are honored to be joined by Dr. Siegfried from Norman Regional Health System. And she is an emergency room physician. And hello, Dr. Siegfried, and thanks for joining us.
Hi, thank you so much for having me. I'm excited to be here
Yeah.
today.
This is exciting because we're seeing a lot of nursing students that are about to graduate and they want to do emergency medicine or ICU, about almost all of them. Yeah, and OB, but they really want to do emergency medicine. So this will be very helpful for them. So,
Oh, perfect.
yeah,
Well, we would be very excited to have them.
I bet. Yeah, you got plenty of patients to see.
Yeah,
Yeah,
yeah, that's right.
right. Do you mind telling us a little bit about your journey to becoming an ER doctor? Did you always want to be a doctor, and what did you have to go through to become an emergency room physician?
So it's kind of funny. Whenever I first went to college, I did it at that time, it was called a pre-med track. And as my first semester, second semester in, and I was just doing, my biology, my chemistries, all those things. I'm like, oh, I hate this.
Mhm.
So I actually ended up switching to business, and I got my bachelor's degree in business management and marketing. And I went out and became a banker for a few years as a branch manager, as a loan officer first, then branch manager. And I kept thinking, I do not love this
Yeah.
at all. It was definitely not my calling. There's a lot of people that it is their calling. I loved the people aspect of it, but the financial aspect of it just was not my calling. And so I thought to myself, I said, you'd gone to school for medicine initially, and I kind of thought to myself, well, what was your setbacks? What made you decide not to do it? And all of it was really kind of the science aspect. And said, well, you're a little bit older now. You have a little bit more tenacity. So why don't you consider going back? So I started taking some prerequisite courses, but then I also decided, okay, well, you can't you got to either shadow or you have to do some things like you really need to make sure that this is it. And maybe it'll give you some perspective for the long haul. So when you're doing your organic chemistry and all of those things that you don't love, something for you to be like, oh yeah, but at the end game, it's this. So I shadowed, and I shadowed in hospitals and in clinics. I had a lot of really lovely physicians who opened up their schedules for me in the OR and all of these places. And in the ER is really where I found like I felt at home. A really wonderful physician. Her name was Dr. Rhiannon Main, and she said, you're welcome anytime I'm on shift. You're welcome to come. And I don't know that she thought I would truly come on a Friday night at midnight, but I did.
Yeah. Awesome.
And I knew then I was like this is for me. So in med school, I tried to keep an open mind about it, but every single rotation that I did on my clinicals, I was like, oh, want to go back to the ER. So if we were taking admits for internal medicine or whatever, I was like, oh, I'll go down to the ER, all of that. And in my third year, another ER physician, his name is Dr. Michael Payne, very fitting for an ER physician, right?
Yeah.
Um, but he was lovely, and he really gave me the full experience. And so then in my fourth year, I bullseyed ER medicine. With when you go through medical school, you go through a match program where you kind of decide what your specialty is going to be. And so for me, I bullseyed emergency medicine. So I spent a very good portion of my fourth year just in various ERs throughout the state and country, and ranked for emergency medicine. And Norman Regional was my top choice, and luckily for me, they had ranked me as well, and so I got to do my residency training there.
Nice. Okay. That's
Yeah,
exciting. Yeah.
yeah.
If I can brag on you just a little bit, I also work at Norman Regional, and when Dr. Siegfried comes up to our codes, um, she's very good. Obviously, she knows her stuff. But what impresses the nurses the most when we talk behind your back after you leave in a good way, uh, you're one of the few that ask us when we're resuscitating someone what our opinion is and what we should do, and if we have any suggestions. And that means a lot to us. So you must value the opinions and the expertise of nurses.
Oh, absolutely. Speaking about that, it just specifically, whenever I come into a code, I kind of walk in and I know 10, 15 seconds about what's going on. But, the charge nurse and certainly the nurse who's been taking care of the patient and in truth, most everybody in there already knows more about it than I do. With codes, of course, there's an art to it, but it's a lot of, everybody knows the drill, but the thing to be most successful is, well, why did we get into this position to begin with? And the only people who are going to know that are the nurses, because they are with the patients the whole time. They know everything that's going on. You all go to school for a long time and you have just a wide breadth well, what's the pathophysiology? And, there's been a lot of times when it's your insight that's invaluable and maybe changes the course and helps us to know kind of next steps.
Yeah. Okay.
Yeah.
So for those who are of our graduates who want to go into emergency medicine, we obviously in nursing school develop some skills and traits for them to be become beginners in medicine. Is there something special if you're going to go into emergency medicine? Are there special skills or traits, or what advice do you have to those nurses who want to go into the ER?
Yeah. So my first piece of advice to any nursing students is the same piece of advice that I have even for myself. Um, you can do whatever you want to do. And so even if you don't necessarily feel like the traits I'm about to explain are like your forte, hard work will get you where you need to go. Kind of the same thing. If absolutely, I want to do the ER, but maybe I'm not the best multitasker, because that's one of the big things you need. Just having the hard work, knowing that I may have to work a little bit harder than my fellow colleagues at it, but you'll do just fine. But so that being said, multitasking is very important, because in the ER, depending on what kind of bed they assign you to. In the ER, there's different acuity beds. So we have, for example, at Norman Regional, there's 45 beds now in this new ER. 6 of them are trauma resuscitation beds. So it depends on, what kind of level of bed you get, but you could have 3 or 4 if it's a lower acuity bed assignment. You could have 3 or 4 patients. And so you need to be able to multitask, because how they do it at our hospital is you're assigned a room. And so you may get 2 rooms almost at the same time of patients. Hopefully not, but you could get them pretty close together. So you need to be able to kind of multitask. Need to be able to not be afraid to ask for help, or say, hey, can I bounce this off of you? Or, hey, I've tried to stick this person twice for an IV. I'm just not getting it. Doesn't say anything less about you. It just means, you know what, this one, we are all there to help each other. There's float nurses to help. There's charge nurses to help. There's docs to help. I always tell patients, I say, listen, they are way better at sticking than I am, but I'm happy to help if we need to. So being able to ask for help, being not afraid, being not afraid to advocate for yourself and for your patient, because you spend the most time with that patient. You honestly, most of the time, have a pretty good idea of knowing what they need. And if you don't, but you just have that kind of spider sense go off, that's like, I don't know what they need, but I know they need something. Being able to advocate for them with either your charge nurse or the doctor who's taking care of them. Those are all pretty important.
Yeah, for
And
sure.
um, in the ER, sometimes you have to have a little bit of a thick skin. Sometimes patients can come in and, maybe they have been drinking alcohol or, whatever, and they're not always the nicest. For the most part, I would say like 95% of our patients are really, really nice, but it's just a part of that, emergency medicine aspect of things, where you never know what you're going to get. And so sometimes you have to have a little bit of a thicker skin.
Yeah. And speaking of thicker skin, a lot of our nursing graduates, we try to help with communication skills when they're in school, but they truly don't know how to communicate when they get out there, especially with physicians. Uh,
Yeah.
there's a lot of intimidation. Um,
Yeah.
Sometimes that leads to, and you may have seen this, leads to nurses not advocating for their patients, not because they don't want to,
Yeah.
they don't want to speak up and they don't want to approach the physician. Have you
Mhm.
seen those communication barriers? And if a nurse is going to communicate with you, how should they do it?
Sure. So first and foremost, at the end of the day, the most important thing is patient care. So whatever we need to do to ensure that we're having good patient care is key. Um, you know, I get it. Even as a resident, and sometimes I was even a little intimidated to talk to other doctors.
Yeah.
So, but we're just the same, just normal, just the same normal. So, I would say at the end of the day, advocating for your patient is most important. If you don't feel comfortable approaching the physician, or maybe you approach the physician, but you don't feel that they gave you the appropriate attention to what you're saying, then, a seasoned nurse would help, or your charge nurse, going to one of them and say, listen, I really tried. Or sometimes I've actually had nurses who we admitted a patient to in the ER, and so they're not under the ER doctor's care anymore, but like we're holding them in the ER for, whether it be for bed assignment or what have you. And I actually, a couple of months ago, I had a nurse who came to me. She was like, listen, I know that this is not your patient anymore. It was your patient before. They're still having a lot of chest pain. I've talked to the other doctor about it. We're getting the EKG, we're doing, of course, what they said, but I just really think somebody needs to lay eyes on this patient again, physician wise. And I really feel like something's off. And so, of course, I went in and saw him and I was like, oh yeah, I completely agree with you. You're right. Something's off. And so I had no problem calling that other physician. And honestly, I said, hey, I'm letting you know, I'm calling the cardiologist as well. Just because again, patient safety, patient care is number one. That's why we're all in this. We're not in it for any type of healthcare provider. We are in it because of us wanting to be helpful and beneficial to our patients. And so that's key. But yeah, other providers, other nurses, um, if no physician should ever give you any trouble if you're coming to them with, those kind of altruistic things in mind.
Yeah. Okay. So the ER is pretty fast paced most of the time, right? So, uh, we teach nursing school head to toe assessment, comprehensive head to toe assessment. It can take 10 or 15 minutes. And sometimes in the ER, you don't have that time. So when you're
Yeah.
going in and when these new nurses are going in as ER nurses, what do you look for to see if a patient is sick or not sick? Are there certain things that these nurses should be looking at to quickly determine which route
Yeah.
they're going to take?
It's funny you say that. So we teach this to the residents about in a 30-second, quick 30-second assessment of sick versus not sick. Um, of course, sometimes sick does evolve with time, but when we walk in the room, do they look ashen? Do they, are they just kind of laying there, like a pile of bricks? Are their vital signs abnormal? How do they look? Do they look unkept? Just basically a head to toe quick assessment with good vital signs can help you. Obviously, if you see them covered in blood, then that's a ooh. But most of the time, that's not what you see. Most of the time, you'll have a patient who's just resting comfortably in bed, and it's honestly the fact that their heart rate's 140, and you're like, oh, do you feel like your heart is racing?
Yeah.
Of course, if they're leaning forward, feeling short of breath, taking big deep breaths or something like that, or if they're not answering your basic questions normally, then those patients are really, really sick. But other than that, I always encourage in the ER, get him hooked up to the cardiac monitor, get him hooked up to the pulse ox, get the blood pressure cuff on, because that can tell you pretty quickly, because sometimes patients will try to trick you.
Yeah.
And then, that heart rate and a blood pressure of 70 over 40 will be like, well, that's not quite
Yeah.
right.
Right. Yeah. So for these nurses, if you for our students that are about to graduate, if you do go in and your assessment is wrong, you need to admit that to yourself and then change course,
Yeah.
because
Yeah.
sometimes we're wrong. Sometimes we think a patient's not sick and then they are.
Mhm.
So yeah, then you have to change course pretty quickly and adapt and overcome.
Yes. Yeah. Adapt and overcome is right. And
Yeah.
there's nothing wrong with getting it wrong.
Yeah.
What's wrong is knowing you got it wrong and not fixing it.
Right. Yeah.
So,
Sure. So let's talk about some clinical topics. We're really starting to teach some differential diagnoses. If we hear a complaint, such as altered mental status,
mhm.
uh, we're trying to train our nurses when they're walking to that room after they see that complaint before they've seen the patient. They need to start thinking about things that they're going to rule out, not
Mhm.
walking in blindly just with a complaint and not already have some ideas in your head. So when you
Right.
get in there and you see that it's an abdominal pain or chest pain, you already have 4 or 5 things in your head that it could be. So
Mhm.
do you mind talking about some differential diagnoses for certain complaints?
Yes,
Okay.
absolutely.
Yeah.
So, again, you're right. Walking in without a bias, that's most important, and especially in emergency medicine, you'll have a fair number of patients that we call them frequent flyers. They come in all the time. I mean, we had a patient, I'll never forget, it's my intern year. Another one of my classmates, she was already well known to us. She came in almost every single day. And she came in with chest pain, which is not necessarily something out of the norm for her. But, not walking in with the bias, thinking the differential allowed my classmate to, keep doing the good things. And, she was having a heart attack. Activated the cath lab, got her the care she needed. So bias is, something important. Whenever somebody comes in with a chief complaint, I try to think of a differential from multiple different organ systems. So for altered mental status, for example, I try to think of endocrine. So, what's their thyroid? Do they have a thyroid history? Things like that. Are they diabetic? So that's for my endocrine. Did they have any trauma? Trauma is always important to keep on your differential. Even minor traumas can have pretty profound pathology associated with it. Then I also start thinking, of course, cardiovascular and then respiratory and then GI. So I try to think of, a differential from each one of those categories. So MI, a PE or a pneumonia for respiratory, is it just gastroenteritis or do we have, bowel obstruction or something that's profoundly caused them some problems or are do they have a history of cirrhosis for their altered mental status? Again, did they fall, did they bonk their head, did they have a seizure disorder history, hypothyroid, are we in a myxedema coma situation? So I try to think of something from each major organ system to kind of help not guide me in one direction but to think of the big picture.
Yeah. Okay. Do you mind? We're going to go over just a couple of like common chief complaints that we see in the ER. And
Mhm.
let's just pretend like you're walking to the room and you see this complaint. Tell us what's going through your mind, and maybe our nurses that'll go through their mind too when they're going. Okay.
Yeah, absolutely.
So let's start. Abdominal pain. That's a big one. That's probably, do you think that's in our top 5 complaints that we see or less?
Easily, easily. Yeah.
Yeah. So a patient with abdominal pain, what would you be thinking when walking to the room?
So then I start thinking about what is my patient demographic? Is this a young, fertile female? Because then I start thinking, do we have an ectopic? Certainly, I think about like my appendicitis, gastritis, things like that. But do we have an ectopic pregnancy here, or ovarian torsion, or ovarian cyst? So my patient demographic really kind of helps to guide me. If it's an older patient population with abdominal pain, are they having a bunch of diarrhea? Are we thinking like diverticulitis? Or is this like a lot of pain and they have a history of AFib and maybe they've got ischemia to their bowel or they've had, 4 abdominal history or 4 abdominal surgeries in the past. So, do we have a small bowel obstruction or something along those lines? So I think that my patient demographic kind of helps to play in. Of course, you never want to miss your surgical emergencies. So whenever I walk in the room, are they very still on the stretcher? Those people are usually peritoneal. Is their abdomen rigid, or distended? It's a very, you can tell they're a petite person, but their belly is really, really ballooned out, those kinds of things. Is it a gravid abdomen?
Yeah.
Is she 35 weeks pregnant? And, are
Yeah.
we having a
Mhm.
pregnancy complication? Those kinds of things. So, and again, what are my vital signs, right? And so if they're really, really tachycardic or low blood pressure, things like that, that kind of helps me to know, hey, I need to, be very diligent and think about that.
Yeah. Falls are another one. I'd say
Mhm.
this is probably in our top five too. So there's many things that can cause it. So I assume that when you're going to the room, you're thinking, number one thing that our nurses should be thinking is, why did they fall? Did they pass
Yes.
out? Did they trip? Are those the things that you're thinking of on the way?
Yes, exactly right. So, you know, eh, that's another thing where it's like you don't want to get biased and you don't want to get yourself like thinking down one path. You don't want to get yourself focused on, well, there's a head lack. Sure, and that needs to be addressed. But, again, you nailed it. Are they having a big MI and that's why they fell and they got the head lack? Or, do they have, aortic stenosis, something not just I tripped and fell. Now, a lot of times they can just flat out tell you, listen, I use a walker. I was just trying to go to the bathroom this time. I didn't use my walker. I slid or I fell. Or they'll say, I always ask, were you having chest pain, feeling lightheaded, feeling short of breath, or nauseous prior to, during, or after the event? And so, I think about that. Now, the other thing with falls that you have to also think about is distracting injuries. So they'll say, oh my gosh, my wrist is just hurting so bad, but you don't want to just get completely focused just on the wrist. Yes, the wrist, maybe it's broken, but you also need to think, okay, well, that's a distracting injury. How is their neck? Do I need to be putting them in a C collar? Did they hit their head? Maybe the wrist is what bothers them the most, but they also have a shortened abducted externally rotated hip, so just not focusing on necessarily just their complaint, but again, the whole picture.
Yeah. All right, we'll do one more. Shortness of breath, probably also up there too. And that's complicated because that can be a whole bunch of things. So we
Yes.
should be thinking on the shortness of breath.
Yeah. Shortness of breath, you're right, because that can be anything from just a simple, my allergies were acting up, or to like a pneumonia, to PE or MI, or, it can be an endocrine thing. Also, like that's one of those things where you'll get short of breath, but it can be for a list as long as my arm is the reason. So again, whenever I walk into the room and it's a shortness of breath, I am looking, are they comfortable when they're laying back in the bed, resting comfortably? Or are they retracting? Are they sitting forward? Are they speaking to me in full confluent sentences? What is their respiratory rate? And I will actually sometimes just count the rate, not going off of what the monitor says, because that's not always the most accurate. And then what's their oxygen saturation, things like that. If they're a kiddo, I'll actually ask them to sing me the ABCs. And if they can sing the whole ABCs, or if they can get to, M or N or something like that, and they didn't have to take another breath, they're doing okay.
Yeah.
So that's kind of one of the things I'll do for kids. But if they, are leaning forward, if they're, audible wheezing, this is another thing where, take your stethoscope in, listen to multiple spots on their back and their front. And sometimes, that'll kind of give you a guide as well.
Okay. Thank you so much. It's been
Yeah.
wonderful. You've really provided some invaluable information for our nursing students. I think it's going to really help them. And do you have any final words for them who want to go to
Um,
nurse?
Yeah, so thank you so much. I am super excited to have been here. I remember meeting you on House Officer my intern year, I think it was.
Yeah,
So
yeah.
it's kind of nice to see for you to be able to kind of see things come, full circle for me. And I'm very happy to impart, any information I have on just to the nurses and the students. I would just say, it is hard job. Um, make sure that while you're studying and all of that, that you take, 5-10 minutes for yourself each day to kind of just reset. Some days will be more stressful than others, but at the end of the day, don't lose sight of why you're doing all of this. And sometimes it'll seem like the struggle is real, but you will get through it. And don't be afraid to reach out to your fellow students, to your nurses who are training you, to whomever, and make sure that you advocate for yourself when you need to.
Okay. Thank you very much.
Yeah, thank you so much for having me. I appreciate it.